Good evening, everybody. Very warm welcome for the second monthly clinical meeting hosted by Surgical Society Bangalore. So I welcome Dr. Bhaskaran sir from MVJ Medical College, Dr. Nagbhushan sir from BGS Global Hospital. Let's start with the presentation. I invite Dr. Monica Pansari to present on breast examination and breast diseases. Over to Dr. Monica.
Good evening, everybody. I'm Dr. Monica Pansari. I'm a surgical oncologist at BGS Gleneagles Global Hospital. At the onset, I would like to thank Surgical Society for giving me this opportunity to share my clinical knowledge with PG students. Dr. Nagbhushan requested me to discuss in brief about clinical breast examination and basics about the breast diseases. So I'm planning to keep my discussion as simple as possible for PGs, for them to understand what basically clinical breast examination is and what are the important points they need to focus upon. So to start with, a little bit in brief about breast anatomy. So breast basically is a glandular structure which is situated from external anatomy. It basically extends from second to sixth rib vertically, horizontally from midline of the sternum to the mid-axillary line. And superolaterally, there's a small axillary tail of spines which goes towards the axilla. So that again, you all need to understand about it because this does play an important role while doing clinical examination. So broadly, breast is made up of three important structures, mainly glandular, fat, and some fibrous ligaments, which we call it as Cooper's ligament, which again is a very important structure to hold the breast in place. So you can see in this picture that what mainly grossly the anatomy of breast is. Breast mainly is made up of 10 to 15 sections, which we call lobes, which ends into small structure called lobules. Lobules and then SNI, which basically secretes, which basically has got a secretory function, and then which is connected to the ducts. Ducts mainly there are again 15 to 20 ducts, which drains into the nipple. So this is how grossly it looks like. Then another important point is the blood supply. Mainly it is supplied by different branches of axillary artery, internal thoracic, and second to fourth anterior intercostal arteries. Venous supply, it again follows the arterial supply, mainly drains into the axillary and internal thoracic veins. Then another important is lymphatic structure. So there are mainly, we divide lymph nodes again surgically or anatomically. So when it is surgical classification, we say level 1, 2, and 3. But when it comes to anatomical classification, we say that there are 5 group of axillary lymph nodes: anterior or pectoral group, posterior or subscapular group, lateral or humeral nodes, then apical and central and apical group of lymph nodes. Then also supraclavicular and infraclavicular lymph nodes, which we need to know clinically about. So these are the 5 groups which I have explained. With the basic information about the anatomy, blood supply, and lymphatic drainage of breast, now we go to the most important topic of today's discussion, that is about the clinical examination. So clinical examination, as a PG students, we all should know that a clinical examination most importantly starts with history taking. History, as far as is concerned, it's extremely important, not only in the breast diseases, any other disease, whatever we discuss, whenever we have any patient to discuss, most important part is to take proper history. So as far as breast diseases is concerned, again, it plays a very important role. Most important thing what we need to understand, what we should know about what we are planning to discuss with the patient, and what questions you have in your mind. To start with, first try to understand what patient has the problems, then you have to go for some kind of questions which you come across and you think that they are relevant things to ask for. So most important is age of the patient. Again, for breast diseases, whenever it is about benign breast diseases, most of the time it is in the younger individuals. increasing age obviously puts at a little increased risk of having malignancies. So age again plays a very important role, but another important thing to understand is that age is not the only criteria. We see these days malignancies even coming in younger individuals. So the most common complaint which a breast patient comes to us is with the lump. So whenever a patient has got a lump, another set of questions which you need to ask is how long the patient is having that lump for, how is the progression, whether it is progressed in size over a short period of time or it has been a long-standing lump. So all these are the important things which you need to ask. Another important thing about the history of pain. Most of the time what we see is that malignancies are usually painless to start with. They become painful only in the later part of the disease. Painful lumps can happen, which is very common in younger age groups. Usually most important could be mastitis, breast abscess in a lactating female, cyclical mastalgia. So all these are the benign breast diseases which can be painful. Malignancies are usually painless to start with. So a lump which is painless could be a malignant lump, especially in an elderly individual. Another important thing is what our patients come to us is nipple discharge. Whenever a patient complains about nipple discharge, we have to ask few questions. What is the color of discharge, whether it is coming from one side of the breast or both the sides of the breast, about the amount of the discharge. Color again is a very important thing because red color always makes us think about something which could, most common cause is papilloma. Then second thing could be a carcinoma also. Again, another important thing as it is pertaining to a nipple is retraction of nipple, which can sometimes be associated a long-standing retraction, which patient has noticed from the pubertal age. It is again very important for you to ask that question, whether it is a long-standing retraction or it has gone inside recently. Then again, ulcers or lumps anywhere else in the body. These are again very important questions, which complaints which the patients usually come to us with. What other questions which you can ask is that if you are suspecting in your history that it could be a malignancy, then another leading questions what you can ask is that, is there any bony pain, headache, history of jaundice, cough, history of weight loss, which can point towards a metastatic disease, which you have to ask the patients if any of these symptoms are present. So these are basically the important questions which you're going to ask in history taking. Another important question which is pertaining to history taking is about their personal history of smoking, alcohol consumption. And another important thing which has to be asked in related to breast diseases is about their obstetric history and lactational history. Any patient who's unmarried, late marriages, having first child above the age of 30 years, non-lactating their children, always puts them at a relatively higher risk of having malignancy. Menstrual history, again very important. Early age at menarche, late menopause, again is a risk factor for malignancy. Family history, again very important in cases of breast diseases, because 5 to 10% of breast cancers could be related to hereditary history also. So first degree relative or even second degree relative having history of breast cancers is again very important. Not only breast cancer, any other malignancies like ovarian cancers, which again puts them at a risk of syndrome, hereditary breast and ovarian cancer syndrome. So you need to elicit the history not only of the breast cancer, but other malignancies also in the family. There's another thing which is very important is that when you are asking about obstetric history of treatment for infertility, because many a times when the patients undergo treatment for infertility, which has become very common these days, they undergo a lot of hormonal treatment, ovarian induction, for which a lot of hormones are used, which again can put them at a relatively little higher risk of developing malignancies at a later age. So when you complete your history, what important points you elicit at the end of history taking is again very important. When you have elicited your history, what is the inference which you're going to get is again very important. For example, an elderly lady in 50s coming to you with a painless lump, with a shorter duration of history, with some risk factor of malignancies, like patient is a nulliparous or had not fed, not lactated her child. So any of these risk factors which you think that could be a relatively higher risk of having malignancy. So that is what the inference of history is. It is very, very important that you keep all these points, what are the risk factors for breast cancer, and elicit your history depending on that. So at the end of history, when you have completed your history as a PG student, you should be able to find out some points which are very relevant and which can lead to some amount of diagnosis, some confusion, some clear your confusion about the diagnosis, what you're dealing with. So again, as I said, history again is very, very important. So these are few risk factors which points towards malignancy. As I said, any elderly lady with the family history, personal history. So these are few points which you need to understand. So this again is a picture where just shown that breast we divide into quadrants. Whenever, like the way you examine abdominal lump, you have 9 quadrants and then you specify depending on that. The same is the case in breast. You divide into upper, outer, upper inner, lower outer, lower inner quadrant, and central quadrant. So if you're examining a patient, you should be knowing about this anatomical orientation, the way you're going to put your clinical examination findings as. So whenever you start with breast examination, there are few important requirements, most important of which is informed consent. You have to inform the patient properly what you're going to do. You have to inform the patient about breast clinical examination. It has to be done. There has to be proper privacy, adequate lighting, and you have to have a female attendant. If a male doctor is examining, you have to have a female accompanying the patient. These are very important prerequisites before you start your breast clinical examination. Examination, again, it includes inspection and palpation. To start with inspection in breast, again, is done in 4 different positions. There are various reasons why we do that. It is done most importantly first in the sitting position with arms by the side, lying down position, hands on the hips and hands up over the head, and with 45-degree inclining, bending forward position. So these are the positions where you're going to do your inspection as inspection is done. Inspection, we know that you are going to clinically examine the patient without touching the patient. So when you start examining or inspecting breast, you need to, with the arms by the side of the patient, examine what is the position of the breast, site, symmetry, size, and shape of the breast. Many times a carcinoma will make a breast look a little smaller than the other breast. So you have to check for the size, shape, symmetry of both the breast. If you can see any obvious mass on inspection, if a mass which is larger in size, you can very well visualize it on inspection. So if you see anything, you have to note it down, which quadrant it is located in, what is the approximate size, numbers, all these things you have to observe in inspection. If you have to also inspect not only the breast, also the supraclavicular region, arms by above the overhead, you have to examine the axillary region as well. You also need to know if there is any skin changes, especially in the inflammatory lesions. You can notice all the inflammatory signs, inflammatory breast carcinoma. So all the skin changes also you're supposed to see, any ulceration. So once you complete the examination or inspection of the breast, you need to see, you need to go to the nipple and areola region. So nipple and areola, again, you have to see all the inspectory findings, whether the position of both the nipples is normal, is there any retraction of the nipple, is there any eczematous changes on the nipple, any discharge which is obviously seen on the nipple. All these are the important findings which you see on inspection. So as I mentioned that inspection, supraclavicular fullness, axillary area fullness, again, you'll have to examine and write it down. So these are the important inspectory findings on inspection. Right, in this picture, you can see that there's an obvious mass here. So you have, when you're doing inspection, you need to make a note of it, approximate size, and all those things you'll have to mention. So whenever it comes to breast, there are few important points which PGs are always confused about. What about puckering, dimpling, and tethering of skin and skin fixity? These are the 2 important things which probably I'll explain in much in detail in palpation. But again, if there is, when you're noticing changes in the inspection on the skin, Always notice if there is any dimpling or puckering of the skin, which usually you will observe it like this, which is seen here. Any skin changes like pudy orange appearance, which obviously will be very visible on the inspection itself if it is present, which you need to make a note of. As I said, nipple retraction, you'll have to, obviously, it is most of the time it is obviously visible on inspection itself. This is how something Paget's disease of nipple looks like. These are few important findings on inspection which you need to look into. Why arms, different positions of the breast, even on inspection? Sometimes the dimpling and puckering or nipple retraction is not so prominent when you're examining a patient with the arms by the side, but when you ask the patient to move arms overhead, you can see that nipple retraction, dimpling, all these changes becomes quite prominent. Another important thing is this, that inframammary region, that area skin, you can visualize or inspect it much better when you ask the patients to raise the hand. So these are few important points which you need to take care when you're inspecting a patient with the breast disease. Then after inspection, when you have noted all your inspectory findings in different positions, another thing what I would like to tell you is that when you ask, there's another position when you ask the patient to bend forward, right? So that again is done when you notice breast usually falls forward when you ask a patient to bend forward. But sometimes if a lump is hard, which is fixed to the chest wall, you might notice that that breast is not falling forward, or that lump is fixed and it is not falling forward. That again is a very important clinical finding, which may indicate the fixity to the chest wall of that lump. So after inspection, once you've done your thorough inspection, next comes the palpation. Palpation again for the breast is done with the palmar aspect of your fingers. It is done both clockwise and anti-clockwise position. Again, it is very important not only to palpate the entire breast below the nipple and areola, axillary region, and the supraclavicular area as well. So as I said, it is done with the palmar aspect of fingers along all quadrants in clockwise and anti-clockwise position. It has to be done very gently without eliciting any pain. And we always examine the normal breast first. And again, different positions. First examine the breast in sitting position and then in the supine position. The reason being, supine position, the breast gets flattened against the chest wall, and even a smaller findings which you may miss, a smaller lump in the sitting position, will be very well felt in the lying down position. So as any palpation, most important thing is to check for the area of tenderness, any local rise of temperature, the way we do in any palpation findings. This is the first thing to elicit. So like in breast abscesses, you will observe that there is inflammatory signs, increased temperature, tenderness. All those findings you need to mention, and you have to be gentle if there is tenderness or any signs of inflammation. So whenever we start our palpation, most important thing what we do is that we confirm all our inspectory findings. Like if you have noticed a lump, exact location of the lump, extent, size, shape, how many numbers are there. We again check for the consistency, whether it is firm, soft, or hard in consistency, about its borders or of the lump. All those things we confirm in our palpation. Then again, we see about the dimpling and retraction of the skin, which was seen on inspection. If there is any, you have to recheck in the palpation findings. Always palpate the nipple and areola region, because there can be sometimes a lump under the nipple and areola. Sometimes you may elicit some discharge on palpation, which was not seen on inspection. Then another important thing in palpation is about the fixity of lump, which we usually elicit in, of course, in palpation. So here again, very important clinical findings. Important thing what we need to understand is what is fixity to the skin, fixity to the breast parenchyma, fixity to the chest wall, and pectoralis major muscle. So these are the 4 important things which you are going to elicit. This again helps you in understanding whether the lump is malignant or non-malignant. Skin fixity is assessed in 2 or 3 things, like, as I said, dimpling, puckering or tethering. This is one terminology, and fixity to the skin is another terminology. Why is puckering and dimpling or tethering happens? We know in the anatomy, we know that there are certain ligaments called Astley-Cooper's ligament. So whenever there's any tumor infiltration into these ligaments, this ligaments gets causes a little puckering of the skin because of the pulling of those ligaments because of tumor infiltration. Whenever this ligaments are infiltrated by the tumor, you can see a dimpling or puckering or tethering of the skin. Now, what is fixity of the skin? That is completely different thing. When the tumor has gone into the subdermal area and the skin overlying you cannot pinch or it is not mobile, that is what is called as fixity to the skin. So both of these things are different, that fixity to the skin and then dimpling of the skin. Both the things can happen in malignancies. Now next is fixity to the breast parenchyma. This again is very important thing because usually the malignant lesions will have the tendency to infiltrate into the surrounding structures. So that is why they will be fixed within the breast parenchyma. Whereas the benign lumps like fibroadenomas or other non-cancerous lumps will not be won't be infiltrating. They'll be capsulated lesions, so they'll be mobile within the breast parenchyma. How do you elicit it? You have to fix the lump, fix the breast with your one hand and try to move the lump within the fixed breast parenchyma with the other hand. If you feel the movement clearly, it means that probably it's free in the it is mobile within the breast parenchyma. If you're not able to feel that mobility, it means it is fixed to the breast parenchyma. Fixity to the breast parenchyma indicates more towards it being malignant. Next again is fixity to the pectoralis major muscle. That again is a very important clinical finding which you will learn in your clinics, how to elicit it. You have to ask the patient to put their hands on the hips and ask them to press it against their hips, and you feel for the tightening of pectoralis major muscle in the anterior axillary fold. If you feel once you have to move the lump over the pectoralis major muscle with the relaxed muscle. Ask the patient to relax, not to press hard on the hips, and then check for the mobility. If you'll feel that the lump is mobile, and then ask the patient to press it press her hands against the hip. That is when you are asking them to make the pectoralis major muscle tight. Once the muscle is contracted, then again check for the mobility of the lump. If you see that the lump is less mobile once the muscle is contracted, it indicates infiltration of the tumor into the pectoralis major muscle. Then comes the fixity to the chest wall. Very basic thing is this: when the lump is not mobile, even when the patient is relaxed, it indicates the fixity to the chest wall. Another test is the way, as I said, that recumbent, asking the patient to bend forward, lump not falling forward, could be an indication for fixity to the chest wall. So even when the patient is not contracting any muscle and you feel that the lump is fixed, it indicates fixity to the chest wall. What is more important here is that that fixity to the pectoralis major muscle, which you have elicited in your clinical examination, or fixity to the skin, or dimpling or puckering, or fixity to the breast parenchyma, is it going to change your clinical staging? No, it is not going to change your clinical staging. That again is very important thing for you all to understand. Once you are done with all these palpation findings for the breast lump, you have elicited all your test, fixity to the parenchyma, fixity to the pectoralis major muscle, all your inspectory findings you have confirmed. After that, next important thing comes is a clinical examination of axillary lymph nodes. So as I said, clinically, we divide axillary lymph nodes into 5 groups. Anterior axillary lymph node, which you palpate against the anterior axillary fold, posterior against the posterior axillary fold, lateral against the arm. You have to, there are various ways to examine it. Probably you are going to learn that in your clinical examination. It's very difficult for me to teach it here. So this is how we do anterior group. For central and apical group, you have to put your arm deep into the axilla, press it against the chest wall. When you take your fingers deep inside, that's where you, towards the apex of axilla, you feel the apical group. Against the chest, when you bring your hand a little down, that is when you feel the central group. And for a lateral group, you can use your other hand and feel it against the head of humerus on the opposite side, or you can examine lateral group from standing behind the patient as well. And after examining axillary groups, you have to examine the supraclavicular fossa as well, supraclavicular group of lymph nodes in both the sides, not only on the side where the patient has got lump, other side as well. So this is what is just the basic information about the clinical examination and important things what you need to know when you're examining a patient with the breast diseases. Elicit all your tests clinically properly. It is very, very important for you to know what all the basics are. Stick to your basics and do your clinical findings as properly as possible. After doing your clinical examination, whenever you have got your detailed clinical examination findings and your history taking findings, which definitely will point you towards, you'll have some conclusion what my diagnosis or differential diagnosis is going to be. So there's a little comparison what I have put it forward. Most of the time benign breast diseases or benign breast lumps can be multiple, but usually malignancies are unilateral. Occasionally
you have left with 5 minutes, Dr. Monica.
Yeah. So then it can be, these are all the important clinical findings. It can be, basically cancerous lumps can be firm to hard, fixity will be there, you'll elicit, they're usually painless. Most important finding is parenchymal fixity, and any other signs what I have mentioned in the clinical examination, you need to elicit all those things. Once you're done with the clinical examination, next important things what comes as is, what are you going to do for finding out what that breast lesion or breast lump is? So that is where the role of triple assessment comes. Triple assessment basically means clinical examination, proper clinical examination, imaging, and pathology. So imaging, what we recommend is basic imaging modalities, either mammography, if in women above the age of 40 years, if you're suspecting anything or patient has come to you with a lump, you'll have to do mammogram. Younger patients, we say that it's better to do ultrasound breast because the breast is dense. Mammogram may not elicit the clinical findings what you are suspecting clinically. So for younger women less than 40 years, ultrasound breast is the one which is recommended. It obviously distinguishes solid from cystic lesion. There are few indications for ultrasound breast, like for example, a benign breast disease patient which you want to keep under follow-up. You'll always do it with the ultrasound breast. MRI, again, a few very limited indications. We usually not use it as often the way we use mammogram and ultrasound. What are the tissue diagnosis? FNACs we use or core biopsy. Both the procedures have got pros and cons. FNAC is a quick procedure where we use very thin needle, and it tells us about the sensitivity is high, but the disadvantage is that it doesn't tell us about the histological architecture, cannot differentiate in situ from invasive malignancies, but again, a very simple and OPD procedure. Core biopsy, we use a thicker needle, better histological diagnosis. We can perform additional tests like immunohistochemistries, mainly what we do for breast, ER, PR, HER2/neu, and all these assessments can be done. So this again is a broad classification. When you have elicited your history, this is what your clinical conclusion should come as, whether it is an infectious mass, breast mass, which is more pointing towards benign or malignancy. So you'll have to come to a conclusion as a differential diagnosis. Most important, these are all the benign breast diseases, what we see most often. I'll not go much into the details of this. You all know about it. This again is very important that you need to know at the end of your clinical examination, if you suspect that lump, it is a malignant lump, you should know what the clinical staging of a tumor is. How do you classify it as T and N staging, especially on your clinical examination. This again is a very important chart for you all. So in a nutshell, I would say that any palpable mass in a woman has to be considered as a potentially serious lesion. Any palpable lesion in the breast needs proper evaluation, triple assessment has to be done. First important step is to confirm that there is a mass which is there present, and get the clinical examination, get the radiology or imaging done. Once imaging and histological diagnosis or examination is done, if you find that the solid lesion is benign, keep it under regular follow-up. A malignant solid lesion should always be managed by a multidisciplinary team to avoid any to basically do a proper management of a malignant lesion. It has to be dealt with by a proper multidisciplinary team for the management. Thank you all for listening.
Thank you, Dr. Monica, for elaborative presentation. So
thank you.
We will move on to the next topic, the management of liver metastasis in colorectal cancer. So I welcome Dr. Venkatachala, sir.
Stop sharing the screen. Stop sharing the screen.
Can you stop sharing the screen from BGS? Yeah. Welcome, Dr. Venkatachala, sir.
Yeah. Good evening, Harish.
Yes, sir. So any questions, you can put it in chat box. So Dr. Monica will answer.
Host
yes, sir. You can proceed, sir. Yes, sir.
Scene?
Yes, sir. You can start, sir.
1 second. Okay. Good evening, everybody. Hello.
Yes, sir. You can proceed, sir. Okay. It's audible.
Yeah. So since there was no other topic to fill in the gap, I chipped in with this presentation. At the end of 30 minutes, you can stop me at wherever I am, because this I will try to keep this topic as much for the general surgeons and the PG students as possible. So as we all know that 50% of the patients with colorectal cancer will develop liver metastasis in their lifetime. Of these, up to 25% can be synchronous, means at the same time as presentation of the primary tumor, and metachronous within 5 years of a curative resection for a colorectal cancer, 25% can develop metastasis. So among them, in stage 2 patients, it's 20%, and in stage 3 patients, it can be up to 50%. The median survival when you don't do liver resection or metastasectomy in these patients is 12 to 19 months, and no patient survived 5 years. So that brings in the importance of resection of the colorectal lesions. So hepatic resection for colorectal metastasis is the standard of care. It is the only potential curative therapy. Complete surgical resection of isolated or multiple hepatic metastasis, there can be a 5-year survival of up to 50%. This 5-year survival of 50% is better than the 5-year survival for stage 3C cancers. So if you resect the liver lesions, the survival is better. So as discussed, the primary curative surgical resection will always result in better recurrence-free and overall survival rates than any other treatments. Resection of solitary colorectal liver metastasis was associated with a 5-year overall survival of 71.5%. Disease-free survival was 50%. When compared to resection of multiple liver metastasis, the 5-year survival can be up to 50%, and the disease-free survival is around 30%. So solitary metastasis always fare better, and it can cure a substantial proportion of patients. Now, when you look into it, cancer is a multidisciplinary approach. So you have to identify who are the patients who are going to fail. When you look into KRAS mutations, BRAF mutations, microsatellite instability, you also look for, these are innovative things happening but not into clinical practice, circulating tumor cells, circulating tumor DNA. CEA is the regularly used biomarker, but it is of more of prognostic importance when it is raised before the treatment rather than when it is not raised. So also we have to use what chemotherapy, what targeted agents, and what biologics you are going to use, and the ultimately you have to balance the risk of recurrence with quality of life when you are planning any treatment. The methods of treatment for liver metastasis are curative. Surgical is hepatic resection with or without adjuvant therapy or neoadjuvant therapy. Palliative means medical oncology, that is chemotherapy. It can be systemic chemotherapy or regional through the portal vein or hepatic artery, or it can be in biologicals like bevacizumab, cetuximab. Surgical palliative surgeries also can be possible, like wedge resections of liver lesions in medically unfit patients where limited surgeries can be done. Ablative techniques like radiofrequency ablation, ethanol injections, cryotherapy, vessel ligations, or embolization of the vessels, chemoembolizations, radioembolizations, therapies, or external beam radiation or stereotactic radiation. So when we look into these things for fit patients, what can be done? Resectable tumor, potentially resectable tumor, unresectable tumor. Unresectable tumor, you give systemic chemotherapy. If it becomes resectable, we will consider here. If it doesn't become resectable, if it's still unresectable, go for palliative chemotherapy or ablations, whatever. Look, portal vein or hepatic artery therapy. Resectable lesions, if you know that surgery is possible, it is a good candidate for surgery, you can do surgery. If these all these 1C, B, 3B, they're all the categories for recommendations. The strength of the recommendation is always good in 1A because it has large scale randomized studies which have proven that. And when it goes to 3B or 4, it is goes to anecdotal studies only which are supporting that. If there is high risk of recurrence, you give systemic therapy. If there is some response, progression or partial response or regression, you consider for surgery. If there is progression, consider for second line systemic therapy. If there is still progression or response, you have to assess and consider for third line therapy or intrahepatic artery therapy, chemotherapy, or things like that. Then potentially, now we know that potential resectable, you have to only look for whether you can do R0 resection with sufficient or insufficient functional liver remnant. FLR is functional liver remnant. I'll come to that later. If both are present or either of them, you have to see whether you can give systemic therapy first and then see whether it becomes resectable, consider for surgery. If it is you give systemic therapy and there is something it is not working, insufficient functional liver remnant, you can still consider of two techniques: two-stage hepatectomy. You can resect the primary tumor and then think of resecting liver metastasis later after chemotherapy, or there is another technique, or you can resect liver lesions, half of them, then go back to resect the other remaining as and when they become resectable. ALPS is associated liver partition and portal vein ligation technique, where the liver is split in the depending on the presence of metastasis area versus the normal liver. The liver is split in the line of planned surgery. It is not completely disconnected, means arterial supply is maintained, portal vein is ligated, bile duct remains there, the biliary drainage is maintained. Then the liver is bound to increase in size, hypertrophy in the normal side, and then they go in as a second stage procedure and resect the affected liver, depending on whether the opposite liver has hypertrophied well to get adequate functional liver remnant. So second stage, you can always consider for any of these surgeries depending on when the functional liver remnant or future liver remnant becomes better. Adjuvant chemotherapy will be considered in all the stages of the disease depending on the standard guidelines. Unfit patients, if it is resectable, if the nodules are only less than 5 centimeters, whether you can do local resections or some form of local therapies like ablations, alcohol ablation, radiofrequency ablation, microwave ablation, all those things can be irreversible. Electroporation, all those techniques can be considered. Ultimately, you have to see that vasculobiliary tract must not be closed when you are doing ablation techniques. If there is any involvement of these or the vascular biliary structures are closed or contraindication for ablations, then you have to consider for systemic therapy or stereotactic radiation therapy. So initially unresectable, always systemic therapy, and nodules more than 5 centimeters, you give systemic therapy, see whether there is progression or whether there is response, whether the patient can go to any of these treatments. If there is progression or unresectable, they can go for palliative or symptomatic treatment. So ablation therapies, radiofrequency ablation and microwaves, they are percutaneous. They can be done as percutaneous open techniques or laparoscopic assisted techniques. They use heat, radiofrequency waves and microwaves generate heat. It can be done using a single needle because the needle is open inside like an umbrella. Cryotherapy is use of cold. Then it needs multiple needles depending on the size of the tumors, volume of the tumor. Irreversible electroporation. Electroporation uses high voltage electric current under the low energy. Up to 3 kilovolt, 1.5 to 3 kilovolt is used. If it is less than that, it becomes reversible electroporation. Here, this electric current creates pores in the cells and that causes cell damage later. This is non-thermal, so many patients can tolerate that better, but it is still in phase 2 studies. Stereotactic body radiation or IFU or high intensity focused ultrasound, which uses MRI, MR energy, magnetic energy to destroy the lesions, are also considered. So if you don't know the liver anatomy, you can't consider for liver resections. We'll come to the liver anatomy again. These are all the tumors in various segments of the liver. You can see that it involves almost segment 4 and segment 5 here. Here in segment 4 and part of segment 3, and here it is in segment 2. Some of the lesions, if they are limited to some segments, they can be easily resected, 1 or 2 segments. So ultimately the goal is, as we know that 10 to 20% of the patients with metastasis are suitable for curative liver resection. Aim is to resect as much tumor as possible with more than 1 centimeter margin and leave at least 25% of functioning liver. For functioning normal liver, 25%. For a cirrhotic liver, 30 to 35% liver has to be left behind. Staging workup. Adequate locoregional control of the primary tumor also should be considered, and absence of any synchronous or metachronous colonic cancer must also be looked into before you consider only liver metastasis resection. Ultrasound will detect lesions more than 0.5 centimeters in diameter. Anything smaller than that cannot be detected. Intraoperative ultrasound may be a superior option to extracorporeal scanning in this condition. Triphasic CT or MRI, as you all know, will allow the assessment of the resectability and also for the volumetry, how much of functioning liver will remain. Means you can calculate it as what is the functional future liver remnant divided by total liver volume and see the ratio and decide how much can be resected or whether the patient is fit for resection. PET-CT scan for non-resectable pulmonary or lymph nodes or any bone metastasis to see the presence of any distant metastasis. Elevated tumor marker CEA will be used for prognosis only if it is elevated preoperatively. Biopsy from liver metastasis is not necessary because there can be risk of tumor deposits, seedlings happening on the needle track. Because as we all know that most often when there is a primary tumor and it has recurred, it is more likely to be from the liver, from the colorectal cancer. So synchronous primary resection means resection along with the primary tumor versus stage resection means you resect the primary tumor, you do liver resection later on, or you do liver resection sometimes first and then the primary is inoperable, you consider for systemic therapy or radiation to that area, chemo radiation, and then resect the primary tumor. Those options can be looked. Potential disadvantages of synchronous resection are there can be, because the procedure increases in duration, there can be increased morbidity and mortality. Intraoperative contamination, because you have resected the colon, there can be contamination there can be stool spilling. This can contaminate the liver surface, resected liver surface, and cause abscess formation. So potentially this results in there can be a potential poor healing and anastomotic leak due to, because you have done liver resection, if the liver function is impaired, if the liver goes into failure, hypoalbuminemia, delayed healing, diabetes, obesity, coexisting comorbidities can cause anastomotic leaks. And also there is a thinking that angiogenesis happens when the liver is healing up and then can cause rapid growth of micrometastasis. So simultaneous liver resection and colorectal resection is as efficient as stage resections according to one argument. So there was no significant difference in complication rate if it's done in high volume centers compared to doing it as separate procedures. The survival curve, as I told you, is 31% at 5 years over disease-free survival, and median survival was 30 months. 5-year survival when less than 5 regional nodes were involved means if you think that stage 3B is 40% is the same as for the liver resection. So liver resection must not be considered as a bad thing. It is better than having multiple nodal disease. So patients with potentially resectable liver disease who have already undergone removal of the primary tumor, then they should be considered for liver resection first before considering for chemotherapy, because chemotherapy will have its own adverse effects also. There are arguments against it also. Patient with unfavorable primary pathology like perforated primary tumor, extensive nodal involvement, extrahepatic metastatic disease, unfit patient should be considered for adjuvant or neoadjuvant chemotherapy prior to liver resection and then be restaged and then assessed for liver resection. Synchronous resection is not recommended for elderly people more than 70 years. If you are removing more than one section of the liver, means trisegmentectomy. Trisegmentectomy means 3 or 4 segments of the liver are removed. I will show you later about. I will talk about that later. Poorly differentiated or mucinous adenocarcinomas are aggressive primary tumors. You should not consider for synchronous resection. Greater than 6 regional lymph node metastasis is also a contraindication because the survival benefit is different. Metachronous resection, preoperative chemotherapy when you give is associated with altered liver function and that can cause increased perioperative morbidity. There are conditions called as chemotherapy associated steatosis or steatohepatitis and chemotherapy associated blue liver. Irinotecan is known to cause steatosis and fibrosis that causes yellow liver. Oxaliplatin can cause blue liver because of sinusoidal dilatation. And more likely in obese and diabetic patients, I told you already, more likely with longer duration of therapy of more than 12 cycles of chemotherapy are given, and then you consider for liver resection, you can have more problems in the perioperative morbidity. So sinusoidal dilatation causing blue liver with oxaliplatin, yellow liver because of steatosis or fat deposition, steatohepatitis with irinotecan. So when you consider for number of cycles of chemotherapy, as I told, when no chemotherapy is given versus 12 cycles or more than 10 cycles are given, you can see that morbidity rate increases. So criteria for resection, as in for any surgery, patient's performance status, extent of disease, and liver function are important. You have to assess the performance status and cardiopulmonary reserve, whether what is the extent of the disease, whether how much of liver has to be removed, more than 25% of functional liver can be spared, cirrhotic, 30 to 35% of liver has to be spared. Less than 3 lesions are always favorable without evidence of satellite lesions or extrahepatic disease. Non-cirrhotic liver, up to 6 segments can be resected, 75% of liver can be removed. Assess the liver remnant liver volume or the future liver remnant by using CT volumetry reconstruction and also child-Cook's score classification, indocyanine green excretion. You all know about this scoring and the classification. Hepatectomy is actually done for class A and very carefully selected class B cases. How do we define resectable lesions? Before you used to say number of metastases, size of the metastasis, less than 3 or less than 3. Size of the lesion is less than 5 centimeter. Extrahepatic disease is not there. We could resect. Now we say that no, if R0 resection is possible, if there is adequate remnant liver, you can do. The problem is before they used to count on only few things and say, okay, this patient is resectable and take. Now we count on multiple things, whether there is lymph node involvement, whether what is the chemotherapy response, what is the fitness of the patient, how much of functional liver, whether he is cirrhotic, what is the child's classification, all these things are to be looked into. So a study of 245 patients in Italy, where different prognostic things were used: size of the metastasis, number of metastases, tumor, liver, how much of liver volume is involved, what is the type of surgery, blood transfusion, age of the patient, preoperative CEA level, all those things, and found that total volume of metastasis, not number and location, is the strongest predictor of survival. If there is less than 25% liver involvement, the survival was better. More than 25% liver involvement, the survival was less. How much was the tumor volume? Depending on the tumor volume, the survival also, as the tumor volume increased, survival fell. So more than 6 regional lymph nodes, I kept telling that survival curves were always better when N0 compared to N1 or anything N2. If it is more than 6 or more than 6 nodes, the survival was less. So you have to take careful decision when considering that patients. So resection of synchronous liver metastasis in patients with greater than 6 regional lymph nodes is relatively contraindicated. 5-year survival with less than 5 nodes is 40%, but not good for more than 6 nodes. Ultimately, functional future liver remnant is the ultimate limiting factor. Surgeons have developed these techniques I told you to increase resectability, associated liver partition, and portal vein ligation for staged hepatectomy and two-stage hepatectomy. You resect some part, go back and resect. Some centers reported high morbidity and mortality reaching up to 30%, but some centers say that we are able to improve the liver volume by up to 90%. Some says that two-stage hepatectomy is better than ALPS in compared to 90 days mortality when they studied on patients with liver metastasis. So two-stage hepatectomy significantly improved resection rates up to 50%, but associated with higher rates of dropout of up to 30% after the first procedure due to disease progression, which may happen during the chemotherapy interim phase period. So what is contraindication if there is complete liver is studied with metastasis? No, you cannot do. Celiac nodal involvement? No. Extrahepatic lung and peritoneal disease, except that if it is limited disease and you can do a cytoreductive surgery, resect the lung lesions, resect the liver lesions, same setting or separate setting, and do IPEC. So those things can be considered. IPEC is not generally recommended when hepatectomy and peritoneal disease is done for large volume disease, particularly liver resections. Unresectable primary, if the primary is not resectable as such, if you resect the liver, then this primary will keep throwing metastasis. The Ekberg criteria in 1986, they mentioned 3 contraindications: 4 or more metastasis, extrahepatic disease, resection margin less than 1 centimeter. But as I told you, with the current criteria, we see into multiple other things also before we consider for metastasis. Ultimately, the tumor volume and the volume of liver, future liver remnant is more important. What are the other contraindications? If both portal vein pedicles are involved, one portal vein pedicle and contralateral hepatic vein, all 3 major hepatic veins or IVC are involved, those patients are not fit for surgery. It's like similar to any liver resection. Poor cardiovascular reserve, advanced cirrhosis, jaundice, if there is hepatocellular jaundice because of liver damage from metastasis or liver cellular failure, hepatocellular failure, except for extrinsic obstruction, which can be relieved. So intraoperative assessment, you can use laparoscopic exploration or laparoscopic ultrasound because unnecessary laparotomy can be avoided in 30% of the cases. Look for malignant ascites, peritoneal deposits, periportal, celiac lymphadenopathy. One study shows that you can still resect some periportal nodes along with liver lesions, but not celiac nodes. Intraoperative ultrasound is superior because it is 100% sensitive, gives additional information in around 30 to 90% of the cases and changes the treatment plan in 10 to 42% of the cases. So either laparoscopic ultrasound or intraoperative ultrasound is always considered. And these things also guide for FNAC and also guide you about the relation of metastasis to major vessels. Most major liver resections, ultrasound is used intraoperatively. So as you know, liver is divided into right lobe and left lobe, anatomical right lobe, anatomical left lobe by the falciparum ligament. You see the hilum will have the portal triad, which will have the portal vein in the back, the bile duct on the right side, and the hepatic artery on the left of the bile duct. So the gallbladder fossa, you're all familiar with. The area between the gallbladder fossa and the falciparum ligament or the umbilical fissure is called quadrate lobe. The area behind the hilum, that between the IVC and the hilum, is called the caudate lobe because of the C shape. So this is the anatomical liver. Now when you divide that according to the Cantel's line, coinoid segments, you know, one is the caudate lobe, 2, 3 are the left lateral lobes, 4 is the quadrate lobe and the adjoining liver, 5, 6 horizontally, 7, 8 above. Lobectomy, you know, no. Classical right lobectomy is the right liver is removed, means segments 4, 5, 6, 7, and 8. Classical left lobectomy means 2 and 3 are removed. Caudate lobectomy is separate. If you are doing hepatectomy, right hepatectomy means you are removing 5, 6, 7, 8. Left hepatectomy means you are removing 2, 3, 4. Similarly, if you look from the under aspects, you can see the same thing. From the IVC to the gallbladder fundus, the Cantel's. So extended right lobectomy means right lobe is this much. If you are removing anything beyond that, It's called as right trisegmentectomy. Means if you are removing segment 4, 5, 6, 7, 8, it's called as right trisegmentectomy. Left trisegmentectomy means you are removing 4, 2, 3, 4, 5, and 8. It comes here, it makes it easier. Right apodectomy means segments 5, 6, 7, 8. Left apodectomy means 2, 3, 4. Extended right apodectomy means trisegmentectomy 4, 5, 6, 7, 8. That is right lobectomy, classical. Extended left apodectomy means left trisegmentectomy, that is 2, 3, 4, 5, and 8. Central apodectomy means segments 4, 5, and 8 are in the center. Left lateral segmentectomy is 2 and 3 segments. Otherwise, if you remove 2 segments, whatever segment, single segment, or it's called segmentectomy, 2 segments is bisegmentectomy. Non-anatomical resection, wedge resection may be considered for poor operative patients and small superficial edge where the tumor are located on the surface. Major hepatectomy is anything more or equal to 4 segments. Minor is less than or equal to 4 segments. And you have to look into number of size of the metastasis and also residual functional liver. I have to thank Dr. Somshekhar and Dr. Zaveri because some of the photos were of their surgeries which I had borrowed when I prepared this presentation long ago. So you can see that left part of the liver is remaining now. The rest of the liver on the right side is removed. Means segments 5, 6, 7, 8 are removed.
You are left with 5 minutes, sir.
No problem. Anytime you can ask me, you can stop. So you can see this, that there is a case of classical right hemicolectomy, and the patient had lesion here in the central area. That segment has been removed, means segment 5 and 8 area. Another patient, segment 6 and 7, you can see that this is a classical case of left lobectomy. You can see that left lobectomy is done. This is what is removed. This 6 and 7 is removed separately, and you can see that this is the amount of central part of the liver is remaining. Wedge resection, as is one of my cases, carcinoid syndrome, I had done. So segment 4 lesion, you can just remove the lesion with 1 centimeter margin. It's almost around 12 years. Carcinoid syndrome patient with low Ki67, she is doing well. So R0 resection is the ultimate thing. If there is solitary metastasis, survival is better. Multiple metastasis, unilateral is next, and multiple bilateral will always be. Number and distribution of liver metastasis does not matter as long as R0 resection is done. So 5-year survival rates are always better from resection with a curative intent. Operative mortality 0 to 7%. Hemorrhage is the most common cause. Liver failure can happen. Perihepatic abscesses, pneumonia, pleural effusion, empyema, pulmonary embolism, biliary leak, or fistula. At 5 years, as I told, this is already discussed. So, negative prognostic factors: advanced stage of the disease, high grade, lymph node involvement, extrahepatic metastasis, extensive resections, large size greater than 5 centimeter, increased number, satellitosis, bilobar distribution, short disease-free interval between the primary and the secondary, synchronous metastasis, fare worse than metachronous, elevated CEA more than 200. And surgical less than 1 centimeter margin is always bad. Please attempt 1 centimeter margins. Okay, so the same thing is again put here. Avastin also can be considered for chemotherapy, cetuximab, but you have to wait for 6 to 8 weeks between the administration of bevacizumab and liver surgery. As you can see the response before chemotherapy and after 10 cycles of FOLFOX, how much response, and tumor becomes resectable, neoadjuvant chemotherapy. Do all the areas where tumor initially existed has to be resected? Yes, you have to. As soon as the tumor becomes resectable, please resect. Otherwise, you won't know how much to resect, and you may end up resecting more. You may have to resect some part and do ablation in the other part. How long do we continue chemotherapy unless resectable? I told you, or maximum response. Then you may have to consider for second line or do surgery and then give second line chemotherapy. Complete response, as I told you, is if in 2 cycles there is complete response, it is very difficult. You have to remove what was planned earlier. You can always do a rescue surgery for colorectal cancer with pulmonary metastases, lymph node metastases, re-go do the liver resections. But again, the 5-year survival will be around 40 to 50% still when you do a resurgery for liver resections, rescue surgeries. This is where it says that 5-year survival will still be good if you do it. Second hepatectomy, 5-year survival up to 41%. Conclusions. So liver resection is the standard of care and the only potential curative therapy with good survival. Death from liver metastasis of colorectal cancer is preventable by timely surgical intervention. Resection is always preferred over local ablation therapies because ablations have to be repeated. After resection, the chances with good margin of 1 centimeter, the chances of recurrence are less. Hepatectomy can be performed for resectable colorectal metastasis with acceptable morbidity and excellent survival following complete cytoreduction only. So synchronous resection in selected patients less than 5 nodes has results similar to metachronous liver metastasis and resection. Surgical assessment and intraoperative planning is important. Methods for increasing the resectability includes preoperative chemotherapy or addition of ablative techniques, staged resections, or preoperative portal vein embolization.
Thank you, sir.
Thank you.